Hey guys, welcome back to my channel, The ENT Resident. Today we'll be discussing a very short topic from thyroid, and that is Hürthle cell carcinoma. You can also now purchase my notes. I have added links in the description. Okay, so let's get started. So, Hürthle cell carcinoma actually previously it was classified as a variant of follicular carcinoma because it arises from follicular cells. But very recently, it has actually been recognized by WHO as a separate identity, and that is because of its having a distinct molecular feature and clinical behavior. So, it is no longer considered a subtype of follicular carcinoma of the thyroid. So, Hürthle cell carcinoma is basically a malignant thyroid tumor which is composed predominantly of Hürthle cells. What are these Hürthle cells? Now, Hürthle cells are also known as eosinophilic cell, oncocyte, or oxyphil cell. These are cells which have abundant granular eosinophilic cytoplasm due to the presence of mitochondria. And Hürthle cell carcinoma comprises about 3 to 10% of all differentiated thyroid cancer. This carcinoma is more commonly seen in elderly women. And as I just mentioned, according to WHO, it is now considered a separate entity and not as a variant of follicular carcinoma anymore. So when you see on histology, we'll be seeing the presence of Hürthle cells. Now, what are Hürthle cells? They are these large polygonal cells which have abundant granular eosinophilic cytoplasm, a large hyperchromatic nuclei with a prominent nucleoli. So, if you see in the first image over here, this image over here, this we can see is a very thick capsule, and we can see a lot of Hürthle cells clustered over here. You can see the abundant eosinophilic cytoplasm in these cells. In the second image over here, these are what Hürthle cells look like. You can see how there is so much of granular eosinophilic cytoplasm in each of the cells, and there is a round nuclei with a very prominent nucleolus inside of it. This is how a typical Hürthle cell looks like. When you come to a diagnosis of carcinoma, it is important to have a capsular or a vascular invasion in the histology. Clinically, when the patient of Hürthle cell carcinoma comes to you, they'll usually present with a thyroid nodule. This can be a multifocal one or even a bilateral case. Usually, Hürthle cell carcinoma is way more aggressive than follicular carcinoma. Hematogenous spread is very common to lung, bone, and liver. And lymphatic spread is also very common in Hürthle cell carcinoma compared to that of follicular carcinoma. When you perform investigations here on performing a cytological examination, you will be seeing Hürthle cells, but you will not be able to differentiate between adenoma and carcinoma, just like in case of follicular adenoma and carcinoma. It is only when you find capsular or vascular invasion that you can make the diagnosis that this is a case of Hürthle cell carcinoma. Other than cytology, you can perform a CT scan and bone scan to rule out metastasis. Coming to treatment, a Hürthle cell carcinoma is a very aggressive tumor, so a total thyroidectomy is the only way to go over here. This is preferred because of the multifocality and higher recurrence risk of the disease. Second, radioiodine ablation in this case is not as effective as others because Hürthle cells have very reduced iodine uptake. So, this is not a treatment modality that works over here. And the patient will also require a lifelong TSH suppression with levothyroxine. That's about the treatment. Coming to prognosis, the Hürthle cell carcinoma has a worse prognosis than that of follicular carcinoma because of its high recurrence rate and very less sensitivity to radioiodine ablation. So that's our short note on Hürthle cell carcinoma. If you have any question on this, please note them down in the comment section and I'll get back to you.